Welcome, everyone. Thank you so much for joining us today. My name is Shayna Salen-Rakowski. I am the program coordinator for the Osher Lifelong Learning Institute at Cal State Channel Islands. For those of you who aren't familiar with OLLI, we are part of a national network of lifelong learning programs designed for adults 50 and above. We provide opportunities for intellectual stimulation and social connection. And offering free seminars like these for our community is part of our mission. We also have our Spring One session starting on Monday, January 26th. Registration is currently open, so if you're interested in taking longer form courses, 2 weeks, 3 weeks, 4 weeks, or 6 weeks, we invite you to check out our course catalog, see what's available, and register for courses and join us for our Spring One session. So today we are here for a wonderful webinar presented by the National Sports Brain Bank at the University of Pittsburgh. I will pass it to Jacob Ponce, who's the outreach coordinator for the National Sports Brain Bank, to introduce our speakers for today. Thank you.
Thank you, Shayna. Good morning, everyone, and welcome. My name is Jacob, and I'll be moderating today's OLLI webinar for CSU Channel Islands. We're very excited to be here. Thank you for joining us for a conversation on concussions and repetitive head impacts and chronic traumatic encephalopathy, what we know, what we're still learning, and what this means for detection, recovery, and long-term brain health. We'll hear from 3 experts, and then we'll save time for Q&A at the end. As questions come up, feel free to type them into the Zoom chat, and then I'll bring them into the discussion at the end. Our first speaker is Dr. Erica Beidler. She's an associate professor of athletic training at Duquesne University. She earned her PhD in kinesiology from Michigan State University, and her work aims to improve the concussion injury experience for both patients and clinicians. She also is the co-director of Duquesne's Sport and Injury Psychology Research Lab, and she helps curate evidence-informed concussion policies for athletic trainers and communities. With that said, I'll pass this on to Dr. Beidler.
Thank you, Jacob, for the introduction, and thanks for having me today. So I'm going to start off by talking just a little bit about some foundational information that my co-presenters will build off of moving forward in the presentation today. Before I get going, I do not have any conflicts of interest to disclose regarding this presentation, and I do have funding through the NIH, the National Athletic Trainers Association, and the Pennsylvania Athletic Trainers Society. However, they don't really weigh too heavily into the presentation I'm going to give today. I'm going to be focusing on talking about some of the social and legal impacts of sport-related concussions specifically by talking about state-level legislation, cultural attitudes towards chronic traumatic encephalopathy, and the role of the media in shaping these narratives. So I want to start with some definitions so we all know what we're talking about today. So we are talking about concussion first. This is a traumatic brain injury, and this definition is coming from the most current international consensus of concussion in sport. So it is a traumatic brain injury caused by a hit to the head or body during sport or exercise that makes the brain move suddenly inside the skull. Some of its characteristics include a sudden movement with temporary changes in how the brain works, symptoms such as headache, dizziness, confusion, or feeling off that can happen right away after the impact or could develop several hours, even to up to 1 day later. Most people will start to recover pretty quickly within a few days, but some symptoms can linger or last longer. Standard brain scans or imaging that you might get at a hospital will typically look normal after concussion, even though the brain might not be functioning normally. And a concussion can have many different signs and symptoms and does not always involve the loss of consciousness. I want to show just a quick graphic of what is actually happening when we get a concussive impact in sport. So this is a AI modeled brain of I believe the venous system from a lab from the Imperial College of London. I think most people might think of concussion as being like your brain is bashing into the inside of your skull and giving like your brain a bruise, but that's not really what we're dealing with here. So this is a 3D model of a concussion that happened during a rugby match that they took a video analysis of it and then reproduced what was happening within the brain. This individual did not actually hit their head on the ground or get hit in the head directly. They had a hard hit to the body, which caused their head to kind of whiplash forward. But as you can see, what we're really talking about with concussion isn't a bruising of tissues, but we're looking at the movement and shearing of internal structures within the brain. And this is what really causes us to have different types of symptoms that people might experience after concussion. So again, it's not necessarily the actual tissue getting bruised. We see the different deficits and changes post-concussion based upon this internal movement of this more gelatinous type substance that is really making up your brain tissue. So that's really what we're dealing with for concussion. And you can have a number of different types of clinical profiles that the UPMC Concussion Clinic is known for, such as migraine, headache, some balance or vestibular type issues, ocular or eye problems. We do see anxiety and mental health considerations, and also just changes in how your brain can think and function throughout the day. So there's many different ways that you can be impacted when you sustain a concussion. The next definition for us is repetitive subconcussive head impacts. These are impacts to the head that are characterized by things that do not actually cause symptoms. So you've sustained an impact to the head, but you are not experiencing dizziness, headaches, or short-term memory losses. So as you're watching sport, you might see somebody get hit in the head. Just because they were hit in the head does not mean that they sustained a concussion, but you could count that as a repetitive subconcussive head impact. So sports that we're concerned about this right now are our collision or contact sports, such as football, soccer, and ice hockey as just a few examples. There's, of course, others out there. So when we think about repetitive subconcussive head impacts, one important thing to note that I think is very positive is that in our society and sport culture today, our current athletes are sustaining a significantly less number of these repetitive subconcussive head impacts than previous generations of athletes has. And that's because we've learned over time it might not be the best thing to hit your head, and especially doing it all the time. So positively, we have seen a significant reduction in just the number of head impacts happening in sport in today's culture compared to previously. This is also an important term to think about because this is the proposed mechanism right now for chronic traumatic encephalopathy, or CTE. So when you hear about CTE, which I'm going to define here in a minute for you, it's not necessarily someone that sustained one or two concussions that we are concerned potentially about CTE, but really when we're talking about it, it is these repetitive subconcussive head impacts that have a cumulative or built-up effect over time on the brain tissue. And again, please note that I have proposed because there's still a lot to learn in this space. So what is CTE? I provided you another kind of jargony definition at the top coming from one of the top consensus definitions at this time. But more generally, CTE is a brain condition characterized by an abnormal buildup of a protein in brain cells within specific areas of the brain. And I'll leave that to my co-presenters to dive a little bit more deeper into that definition for you. But that is really what we're talking about, a neurodegenerative condition affecting the brain. You'll also see in the more fancy definition up above here that they have associated with head trauma. I put, again, that associated with stars around it because there are still a lot of things that we do not understand about CTE. And even this word association might be too strong to be using at this time as we're making connections to repetitive subconcussive head impacts. Important to note that CTE is not a clinical condition. This is not something that you can walk into a doctor's office and be diagnosed with. This is a condition that is only diagnosable after death via autopsy at this time. Long-term research is ongoing to help really define the characteristics of CTE, both at a cellular level, as well as what's really causing it and identifying how it differs from other degenerative brain diseases. So again, there's a lot more unknown at this time than what is known about this. The last definition I'd like to share is traumatic encephalopathy syndrome, so also known as TES. This is a progressive clinical condition. So where I said CTE is not diagnosable by a doctor, this is its counterpart, where you might be diagnosed with TES by a physician using a criteria. But basically, this is characterized as people that have this substantial history of exposure to head impacts. They're presenting with core clinical features that have some cognitive impairments, such as memory issues or executive functioning challenges, and or some neurobehavioral dysregulations. And these features cannot be accounted for by any other medical, psychological, or brain conditions. So again, you can think of TES as the clinical syndrome, where CTE is something that would be diagnosed after you've passed away. And as of right now, even this term TES and this criteria that I'm showing on the screen right now, you can see I've circled in right at the top. This is really still only being used for research purposes. But socially, we are starting to see these terms trickle into diagnoses that patients are getting as they are seeking care for the different challenges they're encountering in life. But really still, even this criteria, still only for research purposes. So those are just some definitions to keep in mind that I think will help moving forward. So I want to turn attention now and just talk briefly about state laws and policies and procedures. So at this time, every single state in the United States does have a concussion state law, and the first one was introduced in Washington State in May 2009. Across the board in all 50 states, there are three primary tenets that every single state law has. The first is that there needs to be education for sports stakeholders, such as parents or guardians, athletes, and coaches, immediate removal from play if a concussion is suspected, and that medical clearance is required for return to play, typically by a qualified healthcare provider, which can be defined differently state by state. So, positive that now we have at the top level across the board some state laws that are directly giving attention to this injury for sport participants. The NCAA also follows these, and they build this out a little bit further. And again, these are just the three basic ones, but there are variations state by state. And when we think about what the true purpose of our state laws are, they're known as a secondary injury prevention strategy, which is geared towards early identification of a first concussion so that they can be removed from play and treated appropriately. We are trying to prevent second impact syndrome, which this is basically when a participant continues playing or goes back to play too soon while their brain is still healing. It's in a vulnerable state. But then they end up getting a second head trauma, hit to the head. And at that point, it can have a catastrophic impact on that already vulnerable brain. So these state laws really have nothing to do with those subconcussive impacts. They really don't have anything to do with this idea of TES or CTE. It's really about identifying that first injury and treating it appropriately to prevent against a secondary, potentially more catastrophic injury. So that's the ultimate function of our state laws at this time. Positively, we have seen the diagnosis of concussions go up as those state laws have been introduced. And that's exactly what we wanted to see. We can't stop concussions from happening through our state laws, but this is showing that we have increased awareness to a level that has allowed people and other healthcare providers to identify the injury, leading to that removal and ultimate diagnosis. So this is a positive finding. These research results are showing that our state laws are working as thought. As we move, kind of the last thought I have to share with state laws is that, as you saw, these were mostly introduced around 2009 to 2014. So we're over a decade removed from most of these state laws, and a lot of them haven't been updated since that point. Since then, though, the research community and healthcare has significantly and rapidly advanced in our understanding of knowledge of this condition. So there are some pitfalls and different variations across states to be aware of. Few states have adopted return to learn guidelines within their state laws, which are now part of our best practice recommendations. But there are a lot of variations state to state. Some places only cover school-sanctioned sports. They don't look at recreational sports. And a big thing, too, is a lot of states don't provide any type of state-level structure to help school districts even implement the state law elements that they are outlining. So still a lot of work to be done here, but at its base level, we are seeing more diagnosis happening than ever before. Now, the last part of my talk, kind of leading into the others, is to talk about some of the psychological and social implications that relate to some of my previous work. So, if you've been paying attention to the sport world at all in sports media, you're going to see headlines like this that are making these connections between this neurodegenerative brain disease as well as playing sports. So, I just want you to kind of think how, what types of emotions this stimulates in you as you're thinking about this, maybe about your own lived experience as an athlete, or your children or your grandchildren's experiences with sport and potentially sustaining a concussion. But these are the images right now that are mainly dominating our mainstream media regarding concussion, head injuries, and CTE related to sport. So I really wanted to understand how people experience this on a more general level. And in a study of collegiate athletes, you can see that a high percentage of them are feeling upset, fearful, worried, and anxious about the idea of sustaining a concussion. And we see that these feelings also correlate with their beliefs that there can be major long-term issues that can come about from concussion, and these tend to also be highlighted more in female athletes. I've also looked at these same feelings in parents and their children. And again, when you look at the parents, you can see a high proportion of parents feeling worried, upset, fearful, and anxious at the thought of their child sustaining a concussion. And their children at the time of the study, these were 8 to 14-year-olds participating in soccer, football, lacrosse, and ice hockey. On the flip side, you can also see that the children, although they have less sport experience and life experience, they're also starting to already show some of these concerns about sustaining a concussion someday. In both categories, we do see these heightened in females. In parents, those that have never sustained a concussion were more likely to report these feelings. And in our children, if the parents had higher anxiety scores, the child also did as well. So some family connections in how we're thinking and feeling about this at this time. I also did a survey looking at CTE mechanism beliefs in collegiate athletes. And again, I want you to revert back. We're thinking at this time, theoretically, that it could be those subconcussive impacts that are building over time. However, a high proportion of my samples thought that sustaining multiple concussions or returning to play too soon caused CTE, which are not really two proposed mechanisms at this time for that condition. Those who reported getting concussion information from sports news resources had higher odds of believing these things were true. And also, they were significantly greater in males and those who had sustained previous diagnosed concussions or had gotten information from the NCAA. So when it comes to those who had sustained the previous concussions and are men, this was an interesting finding because it might be showing that they are seeing these news stories and seeing themselves in the individuals that are being discussed, and then starting to adopt some of these beliefs or think about it a little bit more deeply. We are also seeing socially now professional football players and other types of professional athletes that are making these claims that they guarantee they have CTE, they think they have CTE, and putting it out into the world to hear that. There's really absolutely no evidence for any of these beliefs that they have at this time other than what they have seen presented to them either through their sport organizations or online. But basically what this does is it's creating this narrative of thought that this CTE is a widespread issue. So football players in general, about 10% of college football players believe football-related dementia was likely in their future, and that each additional concussion increased that belief by 24%. So the more concussions they got, the more likely they were to believe they were going to get football-related dementia. 34% of living former professional American-style football players believe they have CTE, and those with perceived CTE reported suicidality at a 5 times greater rate than those that did not. So we're also now starting to kind of, how does this idea that I have this neurodegenerative condition link to how they're feeling about themselves and navigating through life? And this is where we get into this cognitive triangle, where we have thoughts and behaviors and emotions going in a cycle that are really driving how we're experiencing the world and making decisions. And ultimately, we're starting to see this play out potentially in a very sad and negative way. So this past fall, there was a shooting that occurred in a New York City building on July 28th. The individual entered and shot and killed 4 individuals and wounded another. There was a note that was found in his wallet indicating that he believed he had CTE. And there were sources close to the individual that reported he did have an early onset of tackle football participation. He did have medical care that was ongoing for chronic headaches as an adult, and there was a history of mental health issues. But essentially, there's some big question marks right now of people thinking they're living with this disease that can't be reversed. And it can kind of build into maybe manifestation of some more mental health challenges, and that's driving some of these sad behaviors that we're seeing. So with that, I want to pass off to my other speakers, and I thank you for your time and the opportunity to kind of set the stage for you.
Thank you so much, Dr. Beidler. Next, we're joined by Dr. Brittany Rohl, who's a postdoctoral fellow in the UPMC Sports Medicine Concussion Program. She completed her PhD in clinical psychology at the University of Florida with an emphasis in neuropsychology, neurorehabilitation, and clinical neuroscience, and then completed her internship at Northwell Health Staten Island University Hospital. Her clinical and research interests focus on concussion recovery, both sports and non-sports related, with particular attention to how cognitive and psychological factors interact during recovery. I'll pass it on to Dr. Rohl.
Thank you so much for having me. I'm just going to load my presentation here. All right. Oh, sorry, we're at the end. All right. So I'm excited to be here and talk to you today about concussion diagnosis and recovery. Building off of that great information that we just received about what is a concussion, what does it mean for health, and some of those sources of anxiety around it, because that's really an important part of the experience of concussion, as I'll talk about in just a moment. Okay, so first we'll talk about the diagnosis of concussion. What does it look like? How do we know if someone's had one? What are some risk factors for recovery? What makes people take a little bit longer to recover? Is there anything that we can kind of modify to reduce the risk of a longer recovery? And how does treatment factor into that? So up to 50% of concussions are unreported or undiagnosed. That's because a lot of people don't know what the signs and symptoms are. A lot of people still think that you have to lose consciousness to have a concussion, which is not true. We'll go over those signs and symptoms in just a moment. And there's also in sports some pressure to kind of play through it, pressure from peers in different environments, different settings and mechanisms of concussion. This can factor into reporting and diagnosis. So the difference between signs and symptoms here, a sign is something that you can see, it's observable, whereas a symptom is something that you are experiencing, but you might not necessarily be able to observe. You would have to report it to a clinician. So some signs include loss of consciousness, altered mental status. This can be confusion, disorientation, not knowing where you are, what day it is, that kind of thing. Amnesia can happen around the event, so you might lose a little bit of memory before the hit, after the hit. Ataxia, some discoordination in how you're moving, kind of stumbling off the field you might see sometimes, and vomiting. These are things that you can observe in someone else. But there's a lot of symptoms that you can't as easily observe, and you don't necessarily have to have these obvious indicators. So things like headache or pressure in the head, nausea, feeling off balance, maybe to an extent that isn't where you're stumbling, but where you can kind of, that you're not walking as balanced as usual. Dizziness, double or blurry vision, sensitivity to light and noise, fatigue, sleeping too little or too much. There's cognitive symptoms like feeling foggy, concentration and memory problems, and then emotional symptoms. So feeling emotional or down, increased anxiety or irritability, sadness, tearfulness, and even depression. And there are functional impairments. So these are things that maybe you don't see as obviously, or maybe the person might not be able to self-report themselves, but with certain assessments, you can see that they're doing things a little bit differently than usual. They're maybe not as cognitively sharp. They're not as balanced as usual. Their eyes are not moving as usual. Their vestibular system, which is a system in the brain that helps us make sense of movement. So how do we know if someone has had a concussion? There's a lot of different signs and symptoms, like I just mentioned. There's no gold standard diagnostic tool, so there's not one thing that can kind of no questionnaire or scan that can say definitely this is a concussion. And as Dr. Beidler mentioned, if you go to the hospital, you might get a CT scan. That's really used to make sure that there's no bleeding on the brain. And typically only is done when there is some clinical concern for that. So that would be some more severe symptoms like falling asleep and not being able to be aroused, uncontrollable vomiting, that sort of thing. So sometimes people go to the hospital and they don't get a scan and they get worried about that. But that is usually a good thing because it means that your symptoms weren't so severe that there's an indication of a brain bleed. You might have noticed that some of the symptoms and signs that I listed before are kind of non-specific. So there's a lot of different reasons why someone could have a headache, dehydration, for example. There's a lot of reasons why someone could have emotional concerns or concentration problems. And so there's a whole kind of constellation of different signs and symptoms. And every concussion is different and interacts with risk factors, as we'll talk about in a moment. And then Dr. Beidler also mentioned that some symptoms are maybe delayed. So in a proportion of concussion cases, symptoms may not show up for up to a day later. We at the University of Pittsburgh Medical Center take a multi-domain assessment approach. And this involves a bunch of different techniques of evaluating a person for their symptoms and signs of concussion. So it includes a clinical exam, including getting a history and understanding what is the person's baseline for some of these things. Do they have a history of ADHD or migraines or visual problems? The symptoms that they're experiencing in the person's own words is really helpful. We give a neurocognitive test because there may be kind of subtle differences in things like reaction time or visual motor efficiency that may not be necessarily perceptible to the person, but we can compare their performance to people their same age, education level, and things of that nature. Balance and vestibular ocular motor assessments. So this is what I was talking about earlier with that system in the brain that helps us kind of account for movement in the world and in our body. So the way that we look at this is through a series of eye movement exercises, and that will often provoke things like dizziness, headache, fogginess, and nausea in folks who have had a concussion. And then I'm just pointing out here two of the tools that we use for this and that are widely used all over the country for the assessment of concussion were developed right here at the University of Pittsburgh Medical Center. So that's the impact test. It's a computerized test that is used in many professional sports and many high schools and colleges across the country. And then the vestibular ocular motor screening was also developed here, those eye exercises that I was describing. And there's a lot of different symptoms and a lot of different risk factors, but we've now identified over the past few decades that there are certain profiles that concussion symptoms tend to fall into. And being able to identify the type of concussion that a person has helps a lot in being able to treat it efficiently. So you can see the types of concussion here are anxiety, mood, migraine, cognitive, vestibular, and ocular. And these symptom presentations are complicated by things like sleep and neck pain. It's important to note that some of the symptoms overlap in some of these things. So you can have a vestibular type of concussion that also has headaches. It's just that the migraine is not as predominant as it would be in a primary migraine profile. Okay, so risk factors for recovery. We think about risk factors, we think broadly about pre-injury and post-injury risk factors. So women are more likely to have a longer recovery, those who are younger, those who have a concussion history, a migraine history, a history of anxiety and depression, ADHD history, and then also history of ocular problems like having a lazy eye, wearing an eye patch to correct vision that can kind of feed into the ocular and vestibular profiles. If you have pre-existing kind of risk in any of these areas, it just makes those systems a little bit more vulnerable when you get a hit. And then post-injury, when we're looking at the characteristics of someone's presentation after to see how long it will take them to recover, how severe their symptoms are right away, brief loss of consciousness, amnesia, so forgetting things before or after the injury. And I should note here that amnesia is, it's normal to feel kind of stunned. It can be quite a scary event to hit your head hard. But amnesia, what I'm talking about, is like almost as if I describe it to patients as if the memory had been deleted, like it kind of skips forward. Last thing I remember, I was playing on the field. Next thing I remember, I was in an ambulance type of thing. Continued play plays a role in prolonging recovery. Anxiety, depression, and migraine right away. Vestibular and oculomotor impairment, so this will look like dizziness right away. And delayed care. So of all of these risk factors, there are a few that fortunately we can control or mitigate. One is anxiety and depression after the injury. Of course, we can't control whether someone has a history of this. And there's also sometimes post-traumatic stress, depending on the mechanism of the injury. But as Dr. Beidler was saying, there's a lot of fear and anxiety around concussion in society at large. And so improving education around concussion, making sure that everyone has up-to-date information can help kind of mitigate that anxiety right away. And then continued play and delayed care, I'll talk about, are also two modifiable risk factors for protracted recovery. So continuing to play raises the risk for a prolonged recovery, and by that I mean more than 21 days, by 8.8 times. So most people are expected to recover fully within 21 days. This protracted recovery would be beyond that point. For every 1 minute of additional play, there's a 1.5% increase in odds of prolonged recovery. And if you played or trained for 1 hour following a concussion, it can double your recovery time. So the take-home message here is if there's a hard hit and it looks like there's been a concussion, pull them out right away. And then getting care right away. If a patient is seen more than a week after their injury, they have a 6.1 times higher risk for having a prolonged recovery, more than 30 days. And we found recently that days to clinic presentation was the strongest predictor of all for recovery time. So we want to start treatment earlier. That'll get earlier return to sport and school and minimize the cost. So now we'll talk a little bit about concussion treatment. The most important kind of the foundation of treatment for concussion is behavioral management. So we talked just before about pulling an athlete out of play if there has been an impact to the head that has any of the signs or symptoms. Then it was evident, or it was advice for a long time to kind of give brain rest. And that is not the case anymore. So the current guidelines are that 24 to 48 hours of rest immediately after the impact is okay. But after that, you want to start increasing physical activity and really focusing on these behaviors to support a healthy recovery. Because what you don't want to happen is how I describe it to my patients is it's like keeping a cast on for too long. You don't want to kind of decondition the system that has been injured. So gradual return to activity, prioritizing sleep, nutrition, and hydration, and managing stress, like we talked about. Behavioral management, as I said, is the foundation. And then on top of this, depending on what type of concussion folks are presenting with, there are different treatment trajectories that we may advise for them, including things like vestibular therapy, which is a type of physical therapy, exertion therapy, or increased exertion on your own. Walking is really great for this. Of course, when we're working with athletes, we hold them out of full contact practice and games until they're cleared because we don't want to have that second impact. We also use vision therapy and CBT, which is cognitive behavioral therapy or psychotherapy. This is a little bit less often. The physical therapies are kind of one of our primary tools in recovery. And then even less often, we'll use a prescription. This would be typically for the mental health symptoms. And folks may not necessarily need to be on that for a long time, but just to kind of help them through the recovery. So key take-home messages here. Concussion is a treatable brain injury. We can kind of help mitigate some of the anxiety around the injury and recovery by improving education. And up to 50% of concussions go unreported. Non-sport related concussions have a higher incidence than sports. This is car accidents most often, but lots of other ways you can hit your head. Recovery time is predicted by factors both before and after the injury, including immediate removal from play and presentation to a specialty clinic. And a multi-domain approach is used both for diagnosis and treatment. Okay, that's all for me. Thank you so much. And I think we'll do questions at the end.
Yep. Thank you so much, Dr. Rohl. We appreciate it. Our final speaker is Dr. Julia Kofler, who's a practicing neuropathologist and associate professor of pathology here at the University of Pittsburgh, where she directs the Division of Neuropathology and the Neuropathology Fellowship Program. She is also co-director and neuropathology core leader of the Pittsburgh Alzheimer's Disease Research Center. And she's also the director of the National Sports Brain Bank here at Pitt, where she studies the long-term impacts of concussion and repetitive head impacts, including risk and resilience factors related to chronic traumatic encephalopathy. I'll pass it on to Dr. Kofler.
Thank you, Jacob, and welcome everyone, and thanks for joining this seminar about concussions. So I'm concluding this webinar by talking about chronic traumatic encephalopathy, or CTE, as earlier introduced by Dr. Beidler. Jacob mentioned that I am a neuropathologist. So usually you find me sitting behind a microscope or in our growth room slicing a brain. It's usually not pathologists are usually in the background and it's used to being exposed to media. With CTE, that has completely reversed our roles. Since CTE has become a disease that more than many others, the development of the disease and discussions have been played out in the media in a way that we are not used to. So a lot of headlines over the years about the frequency of CTE in football players and other sports, a lot of tragic events from suicides and violent acts that have made it into the media. So a lot of the discussions have been played out. That on one hand has helped in a sense that increased awareness, but it also, as Erica mentioned, had a lot of detrimental impact on how people perceive any symptoms that they develop, and has formed a lot of the narrative over the years. Again, a lot of headlines from violent acts over the years from people who perceived that they had CTE and ended up performing tragic events. However, there's still a lot that we don't know about CTE. So I want to focus this presentation on highlighting some of the things we know, but also informing you about some of the gaps that we still have in knowledge and that we really need to work on closing, so that players, their parents, have a better understanding about the risk for participating in these sports. Because the ultimate goal is not to prevent people from participating in sports, but to make it safer for them to do so. So what do we know about CTE? So CTE is a neurodegenerative disease that has been linked to a history of repetitive head injuries, concussions, or subconcussive hits. It has been seen in contact sport athletes. It has been reported in military personnel, but also under circumstances like intimate partner, domestic violence. People with chronic epilepsy and multiple hits to the head may also be at risk for CTE. It's not something new by any means. The first description from clinical presentations was in boxers more than a century ago. And the first description of football player Mike Webster, Steelers, so there's a connection to Pittsburgh, was about 20 years ago. And this discovery has been immortalized in the movie Concussion. Here, the neuropathologist who made that diagnosis, Bennett O'Malley, and he was portrayed by Will Smith in the movie. Importantly, as Erica pointed out, it can only be diagnosed at this point by postmortem examination of the brain, and that's where the neuropathologists come into play. So how do we do that? So CTE is characterized by the buildup of an abnormal protein in the brain that we call phospho-tau. And the problem with that is that it's not sufficient to just visualize the tau protein in the brain, because CTE is not the only disease that has tau buildup. So a number of different neurodegenerative diseases, including Alzheimer's disease, a number of more or less common diseases are characterized by the buildup of this protein in the brain. So as a neuropathologist, we now need to find additional ways to distinguish these diseases from each other. And the way we are doing it is, once we have identified the specific protein aggregate building up in the brain, we look at which parts of the brain are affected, which cell types are affected, how do these aggregates look like, and potentially in the future, are there different protein conformations, strain types, and other clues that can help us distinguishing one disease from the other. In those pictures, you can see what some of those inclusions may look like. Here on the left, in different cell bodies, in the nerve cell bodies, they can be more round, they can be more flame-shaped, or in the support cells of the brain, they can have different types of star-shaped like inclusions. And as you look at these, you may think, oh, these look all sort of kind of overlapping and similar. And you're completely right with that. And that's where one of the major problem lies, is that all of these interpretations are, of course, subjective. As soon as a human is involved in trying to recognize a pattern, there are differences in how we perceive and interpret these patterns. And that's where some of the difficulties come in making a diagnosis. So what are some of the features specifically in CTE that we're looking for? So here we have some slices of the human brain. And I don't know if you have seen human brain tissue before, but our brains have these sort of irregular surfaces that look like peaks and valleys. The peaks are called gyri, and the valleys are called sulci. And it's specifically the sulci that are vulnerable to building up CTE pathology. And we think is that some of the shear forces or the mechanical forces that the brain is experiencing during a concussion makes the connection between the neurons in these brain regions particularly vulnerable. So anything that's brown is a stain that's highlighting the abnormal buildup of tau protein in these regions. And you can see as in earlier stages of the disease, we may have a buildup here and there, and over time it progresses and those lesions become more confluent. If we zoom in onto these lesions and higher microscopic power, but we can also see that in the center of these lesions are blood vessels. So again, there's an interface between different structures where there are especially increased shear forces that make those regions vulnerable for the tau protein buildup. And what we can now use this pattern to define what the CTE pathology is. So in 2015, a group of neuropathologists came together and came up with some consensus criteria that allowed us to have a more standardized approach to these brains and to have a common language as we can speak to each other to decide, does this brain have CTE pathology? Does it have a different disease, or is it something that's in between and we don't know? There were a number of different problems that we experienced once we started applying these criteria. Before I go into that, this is an example from our own brain bank. This was a male in his mid-20s. He participated in mixed martial arts for about 10 years. So it's not just football, but also a number of other sports that can make you vulnerable He died in an unfortunate accident, and on brain examination, he had definitive findings for CTE. So as I said, as people started applying these criteria, there were a lot of questions that came up. So 6 years later, the criteria were updated to improve clarifications and to also propose a staging system. So we're currently using this system, but there's still already a pretty obvious need that there will be further modifications needed in the future. One of the biggest problems is that many of the brains that are being looked at are from elderly individuals, and there's a significant overlap and co-occurrence with other neurodegenerative and aging-related pathologies. Alzheimer's disease pathology, for example, is really common. If you remember from one of my earlier slides, it's also including tau pathology. It's distributing differently in the brain, but as both CTE and Alzheimer's disease become more advanced, as you can see here in the image in the right, and the left column is CTE, Alzheimer's disease on the right. As diseases become more advanced, the tau pathology essentially affects the same parts of the brain. So it's becoming quite difficult to distinguish in one disease from the other. So this may lead to under-recognition of CTE pathology in older people. There's also increasing recognition that there may be possible CTE subtypes. We still need to improve our staging system. And there's also some uncertainty still at the early end of, so what in the really mild cases, what are the minimum findings to define CTE? So what do we know for sure for now? We have diagnostic criteria that are working reasonably well and allowing us to make a diagnosis based on these criteria. And this diagnosis is pretty straightforward in typical cases. The pattern is fairly specific to individuals who have a prior contact sport exposure. So it's really uncommon to see that in somebody who doesn't have the exposure. But as Dr. Beidler also mentioned, it still requires a postmortem brain examination for definitive diagnosis. There's a lot of work going on in biomarkers, both like blood tests, cerebrospinal fluid tests, and brain imaging studies. But as of now, they still lack sensitivity and specificity to make a definitive diagnosis or make a diagnosis early on and not really just in end stages. In addition to this need for having clinical diagnostic needs, there are a lot of other open questions. And most of them are more at the epidemiological side. So who is at risk for CTE? I've diagnosed CTE in a 15-year-old, but I also know people who are 80 years or 90 years old who are in perfect cognitive health and had a number of concussions during their football careers. We don't know if women have any different CTE risk or features in their brain compared to men. We don't really know if different sports or military exposure change the pathology, although there are some data that are emerging from that. We don't also know what is the relationship between having CTE pathology in the brain and any mental health disorders, suicides, or acts of violence. We don't really know how much CTE contributes to cognition and cognitive decline, and we don't really have tools to diagnose it clinically. So I can't go into detail to all of these open questions, so just going to highlight a little bit of research that has been done in some of them. There's a brain bank run by the military that specifically focuses on military personnel. And they have found CTE in a small percentage of their brain donors. And interestingly, all of those brain donors with CTE had a prior history of participating in contact sports. Even though military exposure did increase risk for CTE, the most common risk factor was contact sports. However, there's also some more recent case reports of some various unique military groups that may be at higher risk for CTE. So this was what's called the U.S. Naval Special Warfare Combatant Crewmen. And those are soldiers who are working in these high-speed boats that are really bumping off the waves. So they have really repetitive impacts from bouncing off these waves. And one of these soldiers came to autopsy and did have classic signs of CTE. A very important study that came out a couple of years ago looked at how much CTE pathology contributes to a person's cognitive decline. So this came from a very large brain bank at Boston University, where about half of their brain donors had advanced or moderate to advanced CTE, and a large proportion of these brain donors also had other neurodegenerative diseases in their brain. And this is something that many people are not aware of, but it's really rare, even outside of the CTE realm. It applies to Alzheimer's disease and any other neurodegenerative disease. They rarely come along alone. There's usually other stuff going on in the brain. So it becomes really hard to decide what's the driving factor of a person's cognitive decline. But there are statistical ways to model that. And in this study, they did such a analysis and found that Alzheimer's disease pathology or Lewy body pathology were much bigger contributors to a person's cognitive decline than CTE pathology. So CTE pathology only came in around number 5 as a contributor. So it's not by any means a major driving factor for cognitive decline. So it's sort of starting to shift this perceived notion that we have that CTE is this major devastating disease that drives a person's cognitive decline. It seems still that other neurodegenerative processes have a bigger impact. That said, we don't know if these other dementias are also in part driven by a person's history of traumatic brain injury. So there's a lot of factors that come into play and bounce off each other that we still need to tease apart. A very important study that was also published a couple of years ago was looking at the brains of younger individuals. So this study was limited to people up to age of 30. And that's important because these individuals don't have confounding aging-related changes in their brain, so it's usually a very clear and straightforward diagnosis. And the study made a lot of headlines because it found that 40% of their brain donors had CTE, which is a very concerning number, but what wasn't really discussed as much in the media, which at least to me is equally important, is how these brain donors with CTE compare to the ones without CTE. And the only really difference there was the ones who had CTE pathology played a little bit longer football than the ones without, but otherwise there were absolutely no differences. And there was a slight age difference, but there was no difference in the number of concussions, the number or in the severity of concussions. There was no difference in the suicide rate or overdose rate. And most importantly, both groups had really high frequency of cognitive symptoms, behavioral symptoms, and mood symptoms. And there were no differences between the children or the young adults who had CTE pathology and the ones who didn't. So there's a lot of other factors that's driving these early deaths that are not really directly related to CTE pathology. So I think we need to get away from this linear relationship that repetitive traumatic brain injuries cause CTE pathology, and then the CTE pathology causes clinical symptoms. The relationship is much more complex, and I by no means put in all the errors that I could think of, but I think at this point we know that mental health disorders have a very complex interplay with traumatic brain injuries. There are other factors like environmental factors, emotional factors, so how we perceive our own concussion history that may contribute to mental health distress. Other factors may contribute to other neurodegenerative processes. And all of this comes together in making changes to our brain that ultimately influence our clinical presentation. So this brings me back to these acts of violence. Like, do we really have any data that say that CTE increases our risk for committing these atrocious acts of violence? And there's very limited data out there. There's only one study that I'm aware of who looked into this, and this study actually showed that NFL players have actually not actually lower the same risk of being involved in homicidal violence, either as a perpetrator or as a victim, compared to the US population. This goes against the notion that having CTE risk is increasing our propensity to commit violent acts. Another problem that Dr. Beidler also alluded to is that all this media attention and awareness is driving this perceived CTE risk in people who participate in these sports and may influence how they perceive their health, like any cognitive symptoms that they may experience or any mood symptoms is automatically being attributed to CTE. And there's sort of this fatalistic attitude about it instead of seeking health care. Because as it turns out, in many cases, these individuals have a diagnosis of clinical depression or sleep apnea, and those are highly linked to having a higher risk of suicide or perceived notion of having CTE. So there's a lot both in the professional healthcare realm, but also at the level of participants and athletes that still requires additional education so that players seek healthcare and just self-diagnose them with CTE. So to summarize, CTE pathology is well defined by accumulation of hyperphosphorylated tau in very specific regions of the brain. However, this diagnosis still requires postmortem brain examination. We still lack a very well-defined clinical correlate, so we cannot make a clinical diagnosis in living individuals at this point. There's a very complex interaction with mental health disorders and other neurodegenerative processes in the brain that still requires a lot of further studies. Many open epidemiological questions that we still need to answer. So if you, as you listen to our presentations, thought about, is there anything I can do to help find these answers? I just want to share a couple of slides about some of the research that going on here in Pittsburgh. So as Jacob mentioned, I direct our sports brain bank, where we collect brains from former sports participants. And the reason we are doing it is because we cannot find answers in animal studies or in cell culture models about CTE. A human brain is much more complex, a different lifespan, different exposures. That's really hard to mimic in model organisms. So we require participation from a large number of people with very different exposures, including amateur and professional participants, different sports, men, women. And so it's a very altruistic effort, but I think it helps promote the well-being of the next generation. So it's really a research that's done to keep sports alive, players as active and healthy as possible. If you think about you would like to learn more, here's our QR code. There's a phone number, email address, and website. Feel free to reach out to us. We're happy to educate more about what options there are for research participation. And all our studies, I know we are in Pittsburgh, you're in California, are done remotely, so it doesn't require any travel to Pittsburgh. And with that last slide, I just wanted to highlight some benefits of brain donation. It's very, of course, beneficial to research. It allows us to study diseases at the tissue level. We can validate findings from other model organisms. And we can also look if there are new treatment strategies, if they are successful. Brain donation comes also with benefits to families and the community. We will issue a detailed report that will provide a definitive diagnosis. One donated brain can be used in a number of different research studies. Our brain bank goes back to the mid-1980s, and we're still using brains from that time. So it leaves a long legacy, and it's a gift of hope for future generations. And with that, I want to close by doing a big shout out to our brain donors, their family, who doing this big step and participating. And it's a huge effort by a number of people that are listed here, and including our funding organizations and the bottom, all the amazing people I have the pleasure of working with on a daily basis. And with that, I would like to wrap up our presentations and hope you have questions that we are able to answer.
Thank you so much, Dr. Kofler. Thank you, Drs. Beidler and Rohl. We can take any questions through the chat. Shayna, how are we doing on time? Do you mind if we go a little bit over?
We have some time for questions.
Excellent. And then I'm just pasting a link to our website below if anyone has any more questions about the brain bank and wasn't able to scan the QR code in time.